Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Rituximab Maintenance Therapy After Autologous Stem Cell Transplant in Relapsed Patients with CD20-positive diffuse large B-cell lymphoma, Choral Final Analysis, by authors Christian Gisselbrecht et al. My name is Jacqueline Rosenblatt, and I'm an attending physician at the Beth Israel Deaconess Medical Center in Boston, Massachusetts, USA. My oncologic specialty is in hematologic malignancies. The manuscript presents the results of an international randomized controlled phase 3 clinical trial in which patients with relapsed or refractory diffuse large B-cell lymphoma were randomized to receive maintenance therapy with rituximab every 2 months for 1 year or observation following autologous stem cell transplantation. The addition of rituximab to first-line chemotherapy has resulted in improved complete response rates and overall survival in newly diagnosed patients with diffuse large B-cell lymphoma. However, long-term survival is poor for patients who do not obtain a complete response and for patients with relapsed disease. These patients are considered for consolidation with an autologous stem cell transplantation. Rituximab maintenance therapy following autologous transplantation has shown encouraging results in phase 2 studies, but has not been evaluated in a phase 3 clinical trial. The CORAL study is a phase 3 multi-center randomized clinical trial that took place in 12 countries. In this trial, patients with relapsed or refractory diffuse large B-cell lymphoma were randomized to receive salvage chemotherapy with either RICE or RDHAP. Patients who responded to chemotherapy underwent autologous stem cell transplantation. In the post-transplant setting, patients were randomized to receive maintenance therapy with rituximab every 2 months for 1 year or observation. This manuscript summarizes the results of the post-transplant maintenance therapy randomization. Patients were randomized 1-to-1 to receive maintenance therapy with rituximab or observation in the post-transplant setting. Patients were stratified according to country, prior therapy with rituximab, and relapse within 12 months of diagnosis. The primary endpoint was event-free survival. Secondary endpoints were response rate, progression-free survival, overall survival, and toxicities. Power analysis revealed that to detect a 15% change in the 2-year event-free survival from 50% in the observation group to 65% in the maintenance rituximab group, with an 80% power at the 5% significance level, 240 patients were required for randomization into the 2 treatment groups. Patients aged 18 to 65 years of age with aggressive CD20-positive large cell lymphoma that did not go into remission following chemotherapy or that had relapsed were potentially eligible. Patients with CNS involvement, history of HIV infection, or post-transplant lymphoproliferative disease and inadequate organ function were excluded. 481 patients were randomized to the RICE or RDHAP arms. 255 patients with chemosensitive disease received consolidation with an autologous transplant, and 242 patients were randomized to receive maintenance rituximab, 122 patients, or observation, 120 patients. There were no significant differences in the patient characteristics, including age, sex, stage, age-adjusted IPI, time to relapse, prior rituximab therapy, or response after salvage therapy between the 2 maintenance therapy arms. Response was assessed using the International Working Group criteria. Post-transplant follow-up included a physical exam every 3 months for the first year, with a complete evaluation at the end or sooner if clinically indicated. Subsequently, follow-up was performed every 6 months for 2 years, with a CT scan of the thorax and abdomen performed annually. Analysis was performed on an intention-to-treat basis. The overall response rate after salvage chemotherapy was 63% in the RICE group and 64% in the RDHAP group. 245 patients received BEAM and an autologous stem cell transplant, and 242 evaluable patients were randomized to maintenance rituximab or observation. 67% of the patients randomized to receive maintenance rituximab received all 6 cycles. The primary reason for not completing therapy was disease progression. At the end of maintenance therapy, CR rates were 57% and 50% for the rituximab and observation groups respectively. For patients who were transplanted and randomized to maintenance therapy, there was no statistically significant difference in the 4-year event-free survival in the rituximab versus observation groups. 52% in the rituximab group, 53% in the observation group. Similarly, there was no significant difference in overall survival or progression-free survival between the maintenance groups. In a subset analysis based on gender, the 3-year event-free survival was 43% in males versus 69% in females in the rituximab arm. There was no gender difference in event-free survival in the observation arm. Before day 100 post-transplant, there were 87 adverse events reported in 54 patients in the rituximab arm, compared to 75 adverse events reported in 50 patients in the observation arm. More than 100 days post-transplant, 75 adverse events were reported in 35 patients in the rituximab group, compared to 24 adverse events in 20 patients in the observation group. Most of the adverse events were related to infections. The rate of grade 3 or greater delayed neutropenia was 9% and 6% in the rituximab and observation groups respectively. There were 6 deaths in the rituximab group and 2 in the observation group. This study suggests that maintenance therapy with rituximab following autologous transplantation does not reduce the risk of relapse for patients with large B-cell lymphoma. In addition, an increase in toxicity due to infections was observed after day 100 post-transplant in the rituximab arm. The promising data that had been reported in 2 phase 2 studies evaluating maintenance rituximab post-autologous transplantation is not supported by this phase 3 multi-center randomized controlled trial. Notably, in a subset analysis, there was a significant difference between males and females who received rituximab maintenance therapy, which was not observed in the observation arm. The role of gender and possible hormonal pharmacokinetic variations affecting response to rituximab merits further study. In summary, the results of this randomized phase 3 clinical trial demonstrate that for patients with diffuse large B-cell lymphoma undergoing autologous transplantation, rituximab maintenance therapy post-transplant does not improve event-free survival or overall survival and is associated with increased toxicity. The post-transplant setting for patients with relapsed diffuse large B-cell lymphoma remains one in which novel therapies, including targeted and immune-based strategies, should be evaluated in an effort to improve survival. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.